Friends, it's snowing in Istanbul, it's winter, and snow is a rarity. But the quality of medical care is still at the same high level. So stay with us, watch the video until the end. Friends, this is Andrei Berezovsky, the Hexplorer channel, the health channel. And today we continue our line of discussion about the so-called cancers, or so-called cancers, blood cancers or cancers of the lymphatic and proliferative system. And today it is lymphoma. Fortunately, why? Because knowing about this isn't so essential until unfortunately it affects you, such as when it becomes personal. Fortunately, many do not understand the difference between lymphomas and leukemia. What is the difference? What are the treatment approaches? And these are completely different treatment approaches. How does Hodgkinskaya differ from them? About Hodgkinskaya, where did this name come from? What are the prognoses for Hodgkinskaya lymphoma? What are the prognoses for non-Hodgkinskaya lymphoma? What are the modern treatment methods for these diseases? Let's call it lymphoma, but in reality, it can occur in almost any place because this is the lymphoproliferative system. It's not just about lymph nodes. That's not the point at all. The professor will explain how everything works, what modern diagnostic methods are, and what modern treatment approaches exist. How important is it for the hospital or the place where you receive treatment to be equipped in one way or another? How important is it for you to have a team during your treatment? This is your life after all. Friends, I've already said this 100 times, millions of views in total on my channel. And it's all the same. So you're trying to find a loophole, some kind of... But not about saving money. Ooh, but yes, there's no point in saving on your health. And the issue right now isn't about prices at all. There's no alternative. This is your life, which is why we hire the best doctors in the world, and they answer your questions. Today is exactly that kind of case. Thanks to the memorial for this opportunity, we are in snowy Istanbul. Sometimes it seems like life just stops, but we move on because we have wonderful doctors who help us understand the most complex topics. Today we're talking about lymphoma. This is the memorial. Andrei Berezovsky, this is the Hexplorer channel. We answer the most complex and important questions about medicine. And you... Look, let's go.
As you know, in bone marrow, we have two parts. The first part is the myeloid part, which means your blood-producing tissue. The second is the lymphoproliferative part, which is responsible for your immunization, for lifelong, both for the so-called inborn and then adapted. They are capable, and so lymphomas and the lymphocytes are together, and these are actually a hematological problem. All lymphocytes generates in the bone marrow, and any lymphoma is also a part of hematological disorder. Sometimes they are nodal, which means you can palpate it, like your tonsils. You have a lump on your neck or on your groin or on your axillary side, or sometimes they are hidden in your stomach, in your intestines, and these are called extranodal, or sometimes in your brain. These are lymphocytes coming together, and they are building a clonal, likewise a B cell or T cell proliferation, and this is outside of the control of the human body, and this will cause a lymphoma in any tissue, from the eyes to the brain, from the skin to the gut. You will have. It should not be only in the bone marrow or in your lymph nodes. They can appear anywhere where lymphocytes are. The reasons for development is nearly the same, almost always the infections, the radiation, and the constitutional factors, environment factors, the pollution, smoking, etc., even the hair dyes or your nail brush, they can cause on the frequent. In lymphoma case, we always tell about repeated antigenic exposure. You may have an infection in your stomach like an Helicobacter pylori, which is actually present in nearly 70 to 60% of the population, but in a few, these recurrent infections are causing these so-called gastric marginal zone lymphomas, and they are more or less always related to this infection. Sometimes hepatitis B and C are closely correlated with marginal zone lymphomas, and we have a few issues also with the EBV infections, like in Hodgkin's disease especially, and then the other human herpes virus is also many times related to some special rare lymphoma diagnosis. So this is the lymphoma actually from the point of view. If you think, so you will think Hodgkin is more and non-Hodgkin's is less, but this is because of the historical view. So we know the Hodgkin's disease nearly more than 200. Thanks to Hodgkin, and who was actually a pioneer in the field and was a milestone for describing the disease of a lymphoproliferative disorder, very in detail. After many years, then we have another. These were not Hodgkin's disease, and they are called non-Hodgkin's. But non-Hodgkin's are now more than 85%, which is actually the majority. In both diseases, but especially in Hodgkin's, we made a big progress. Because Hodgkin's is itself is a different entity. Sometimes we don't call it lymphoma, a disease. Only 1% of the mass is only Hodgkin's cells. The other ones are inflammatory cells. They are actually driven by the Hodgkin's disease cells. If we eradicate the Hodgkin's cells, then we will see these all inflammatory cells are gone, and after 2 courses you will see that the patients are in remission. In Hodgkin's we have made big progress both in biology and in treatment. In early stages 95% of them are nearly cured. In advanced stages 65 to 70%. Formerly we were only stuck to radiotherapy and chemo. Now we have monoclonal antibodies, checkpoint inhibitors, and again the autologous and allo transplant, but which are used less now. We have many tools like 5 or 6 lines of therapy for any Hodgkin's disease, which is not actually cured at once. So in relapse refractory setting, we are also now very successful in the setting of Hodgkin's disease. In non-Hodgkin's, you see in the diffuse large B-cell lymphoma, which is the most frequent one, and these are treated very harshly. Till 10 years, we could not make too much progress in the field because of the unknowns issues in the biology, differences in the actually pathology. But now, after several versions of WHO identification, now we are getting more pathological and genetical clues, and nearly 80 to 85% of them we are capable. In the high-grade ones, we are still struggling. We are trying to match them upfront high-dose chemotherapies and pathway inhibitors and several combinations, maybe the CAR T cells or BiTEs or TRIDES, these double engagers or triple engagers. Now our tools are also increasing with thanks both to immune effector cells and then followed by these TRIDES and BiTEs.
Like friends, the linear accelerator is working. Boiled. We are at the Şişli Memorial Clinic. As you know, it's impossible without this thing. Today, the quality of treatment and the technology is just incredible, meaning maximum targeting of the tumor with minimal damage to healthy tissues. Laboratories? Healthy tissues? in general. Today, it's not something that good manners dictate anymore. No one talks about the tone, they say it's just necessary. Availability. In a top-notch clinic, we're at Şişli, and we have 2 linear accelerators here, meaning 2 machines. We saw the top Electa in Bakçarev. Well, listen, there's nothing to discuss. These are top clinics, world-class, so the equipment here is top-notch.
Lymphomas, we always tell, you cannot be delayed in the lymphoma setting because lymphoma patient will have a symptom. They are very actually peculiar. First, you may have fever, unexplained. Second, you may have night sweats, but it should be not like less. It should be more than 1 or 2 liters. You will have an unexplained loss of weight, unexplained, unintended, within the 6 months, more than 10% of your actual body weight. And in a few cases of Hodgkin's, they have itching. These are the so-called B symptoms. But you may have a lump, mostly in the lymphoma, in CLL case, in your groin or axilla or on your neck, or maybe you can't speak. You will be low in your sound, in your speaking, that there's a mass, or you may have pain, or if this is in your head, you have a central nervous lymphoma, then we will have neurological problems. It's up to the place of the mass and up to the biology of the. Some of them are aggressive lymphomas, which means they are growing very rapidly. They will come over easily. These are aggressive disease, but in kind of indolent disease, maybe we will diagnose these patients after 3 or 5 years because they will have a slow progressing issue in the abdomen, in their stomach, or in their gastrointestinal system. Maybe accidentally we will find them during a controlled gastroscopy or colonoscopy, or in a regular checkup by CT or lab result. In the lymphoma diagnosis, the most important issue is your pathologist. This is the most important issue. You should take a sufficient portion of the lymph node. Sometimes we always see the problem, these needle biopsies, which we do not accept unless there is no option. We always say if they're in the mediastinum, we do it with the mediastinoscopy now or laparoscopy. But we need always more tissue to make a definitive diagnosis. It's called excisional biopsy. The lymph node should be removed with all its counterparts, which means as a whole, as a part. And if this is done, then your pathologist will be sure we will do the necessary genetic test, flow cytometry, and everything which we are capable in memorial, and then you will have the definitive diagnosis. It can only say diffuse large B-cell lymphoma. It won't help us. Any pathologist can tell that. But this is a diffuse large B-cell lymphoma with these genetic aberrations, with these flows, with this type, then it matters. Then according to this, we will decide to have a different chemotherapy regime, targeted treatments, etc. This is very important. The diagnosis by the pathologist and supported by the genetics, and this is the main start. If you are stuck here, then the treatment won't help you. You do right diagnosis with the right hands, with professionals, supported not only with the pathology, flow cytometry, genetics as well. And then second one, the staging. You need a fantastic nuclear team for PET CTs or PET MRIs, and then you need a CT or MRI for with contrast. Then we see what's the disease staging, and then we can move forward. Now in Memorial, we are trying that we have not only PET CTs, that we do both PET CT and IV contrasting in the same, so we will have a diagnostic CT and PET as well, both as a functional imaging and static imaging, diagnostic imaging.
So we're in the PET City department. We're at Memorial Şişli.
PET-CT is basically the gold standard for diagnosing cancer today. This is a radioisotope study at the level of, basically it's molecular, where they determine if there's any spread of the disease. And today, basically almost, I don't know, at half cancer diseases, the use of PET-CT shows whether we can proceed to full treatment, whether there will be a complete recovery. PET-CT costs around $700. But the most important thing in the subnet is not that it's the gold standard, but that in principle, well, what's the problem? The problem is with the queue for the radioisotope material. He has a saw, the half-life, they bring it in, they order it. There are entire special rooms where they enrich it. Actually, this radioactive glucose, and there are not only glucose-based substances, since there's a constant flow here, you don't have to wait weeks, months, or however long. You arrive literally a few days and you're ready at iPad City. A lot when it's used in many studies.
Because of the 15 years was also very big achievements in the field of Hodgkin's disease. I mentioned with the German Hodgkin study group meetings, we are avoiding radiotherapy now. We are trying to use less bleomycin, which is toxic to the lungs. We are using only 2 courses, maybe in the future never. And we are treating the patients with fixed lines, not 8 courses, but 6 courses, maybe in the future less. For advanced disease, we are now trying to use more targeted therapies, not the classical ones like ABBD and etc. We are moving to monoclonal antibody, anti-CD30, brentuximab, and now we are using also the checkpoint inhibitors timely because they are working fantastic in Hodgkin's disease. Now our chance for less chemotherapy, more targeted treatments, and with the PET-CT, very definitive treatment decisions, because we are taking an interim PET after 2 cycles, then we are sure if the treatment is functioning or not. Then we can change. If everything's okay, we lessen the therapy. If not, we strengthen the therapy, but just after 2 courses, not later. In the setting of diffuse large B-cell lymphomas, the story is a bit different. Now we have differentiated one. This is not only diffuse large B-cell lymphomas, there are higher grade of them, and for them we are starting with more advanced multifunctional treatments. Even we are using the ibrutinib and like this stuff to make a deeper control, especially in mantle cell lymphoma. Now there are trials that with ibrutinib we can control the disease more deeply. Even we won't use autologous stem cell transplantation for consolidation. These are the steps. In the relapse refractory setting, the use of CAR-Ts, glofitamab, mosunetuzumab, like these monoclonal antibodies and double engagers for control of the deep disease, and then move on, bridging to allo transplants are the mainstays of aggressive lymphoma.
A distinctive feature of the memorial clinics is their own Starbucks. Starbucks in the clinic. It's practically California for you. So look, Starbucks.
If you're a cancer survivor, what should you do to make your life better? The first is actually control of your life, and it starts with control of your physical problems, no obesity, and activity. Exercising, not straight, but regular exercising, and outside, not in-house, outside, please. The second, fluid intake. You should be very careful about your kidney functions. The third, infection control, immunizations, social distancing, and mask wearing, especially after 2 years, which you are still compromised. And the third one, controls, not only focus to your disease, but to your the other problems like the metabolic problems, metabolic syndrome, atherosclerosis, your lipid control, and then followed by bone health, your reproduction systems, if you need any medications, supplements. This is an integrative approach. You should be always able of any anxiety. Your social life, your sexual life, and your business life should be in an equilibrium. These are the mainstays. In bias now is the main goal for the so-called survivors, that they maintain nearly 85 to 90% of their former life again. This is called they should be back to their life, not only in social platforms, in business, in their sexual life, in their daily life with the children, and the birth rates, etc., reproducing capability. These are actually the mainstays. And so every cancer survivor should be carefully request from their physician, if they are not interested, from clinics like us, which are focused to life after survivorship, which means we have treated your cancer, and if you are cured or not, doesn't matter. You should be under meticulous control, but in a systematical way, a multidisciplinary team with the endocrinologist, ophthalmologist, skin professionals, dentists, physiotherapists. This is a teamwork, and these are called late effects clinics or survivorship clinics. You should be under control till your end of life. This is the way that you will stay controlled. No one can assure you that you won't have any problem, but there are preventive measures, there are periodic controls, and then you will be aware about your problems beforehand, and then we will go to the preventive measures, the prophylaxis, or either treatments. Then you won't have problem like your healthy counterparts. We are trying that you live like your healthy counterparts, which are on your same age and same gender. They are cured, actually, 94% of the early ones. This is fantastic. This has been published in Time and many times. In Hodgkin's, we are in good hands. In the non-Hodgkin's disease, we are moving forward. If you have a lymphoma or leukemia or any kind of hematological malignancy, you should be careful. This is not like solid tumors. These are liquid cancers. They can be cured, they can be controlled, and we have enough vehicles if you have relapse or refractory. This is quite different than solid tumors. Do not actually mix them with the solid tumors. Hematological malignancies, leukemia, lymphoma, myeloma are curable in many assets. They are controllable and manageable. No right for frightening for any hematological malignancy. You should be in a supportive way with your physician, in good collaboration with the late effects. You will be actually living longer than anyone.